There is Adamu is not. Okay. Yeah. Okay. Now everybody can hear me.
Yes, sir, I can hear you.
Yes, sir.
Yes.
We can hear you.
Okay. Now I think now we have come back to the system. It is working. So with technology, there is more problem on these things. But then it helps us also. Okay. So we can start with the block 3, unit 13. And uh, on disaster medicine, the basic thing we were, the first thing is that disaster medicine aspects are quite critical in disaster management, isn't it? I mean, because there are injuries, deaths, so you require medical intervention. And then after a disaster, there are health problems. So uh, epidemiological uh, care has to be taken. And while uh, catering on to the medical aspects, we look towards the uh, divide everything during disasters or in the whatever is related to disasters into two very clear cut things. One is on site and one is critical care management, that is hospitals, at the hospitals. So what is the action to be taken at the site? So there you will be doing emergency, rescuing the people, giving them first aid or emergency help, whatever can be done to save lives first thing, then is save the limbs. So we have gone through the system of triage, evacuation, and in the all these victims who are injured, and some of them would be injured quite severely. They'll be in critical case. They have to be sent, transported to the hospitals. So where again the separate um, measures are there. So today we have done the first 12 units. So 13th unit we can start off today, and here um, we are dealing with rehabilitation, psychological rehabilitation. So psychological aspects of disaster management or psychological help to the victims, and also to the people who are working there. Some of them also may get affected psychologically, because they see so much of destruction, so much of trauma, so much of, these are not normal things. Disasters are not normal times. In fact, it is opposite of normal time. So the mental health, then post-traumatic stress disorder and how it develops and the stages of PTSD, then mental health interventions, mental health management of the disaster rescue and response workers, all these are covered in this. So now disaster would help affect both the physical health and the mental health. So physical health we had covered earlier. Now mental health consequences. In fact, generally we are not paying importance to it, but this should also be given from right from the planning stage itself. You should cater for it. So public in the public health problems also mental health should be a part of it, because the survivors they have faced danger, death, injuries, and then loss of homes, possessions, communities. So the stress level becomes very high, and their behavior and emotional readjustment uh, become problematic. So these are the things you require psychological rehabilitation intervention. Now, children and adults both experience stress related impact, like first is emotional reactions. So these are temporary feelings of shock. Uh, it could be after several days also, or a few weeks afterwards also. So emotional feeling shock would be like, and then they'll feel fear. They will have grief, anger, resentment, guilt, shame, helplessness, hopelessness, or emotional numbness. So numbness means they have difficulty feeling the close people who are around, their intimacy or love from there, or difficult taking interest and being happy in day-to-day activities. So this become numbness. They become, and then second is type of thing is cognitive reactions. Cognitive reactions would be confusion, disorientation, indecisiveness, worry, shortened attention span, difficulty concentrating, memory loss, unwanted memories, and self blame. So, third thing will be physical reactions. So, these could be tension, fatigue, edginess, difficulty sleeping, sleeplessness, that is, bodily aches or pains, startled reactions, fast heartbeat, nausea, change in appetite, change in sex drive. So many things can happen. And then fourth is the interpersonal reactions. So relationships at school, workplace, with friends, within marriage, as a parent, distrust, irritability, conflict, withdrawal, isolation, feeling rejected or abandoned, being distant, judgmental, over controlling. All these are the what the survivors can experience. It could be any one of them, more than one of them also could be there to a particular person. Now, um, mental health services, they work toward restoring psychological and social functioning of individuals and community. So, and also in limiting the occurrence or and severity of adverse impacts or disaster related mental health problems like PTSD, depression, substance abuse. So, disaster mental health management, it should aim to be humane, competent, and compassionate care of all the affected people. So, so as to prevent adverse health outcomes and enhance the well-being of the people, communities, individuals, families. So, appropriate methods to uh, prevent the development of chronic and disabling problems of mental health should not be there. Like, what are these problems? These could be PTSD, we just spoke of. Then this could be depression, alcohol abuse, and relationship difficulties. So, mental health problems, you don't see injuries straight away, but the behavioral changes which come and it leads to problem. Now, okay, what are the basic principles of emergency care? So, which we should remember is that first is provide for basic survival needs and comforts. That is liquid, food, shelter, clothing, all this for um, survival needs. Help survivors achieve restful and restorative sleep. Then preserve an interpersonal safety zone, protecting basic personal space like privacy, quiet, personal effects are there. So, yeah. Then provide non-intrusive, ordinary social contact. Use of humor, small talk about what's happening around, silent companionship. So these are the things. Then fifth is address immediate physical health problems or exacerbations of prior illness. Then assist in locating and verifying the personal safety and of separated loved ones or friends. Then reconnect survivors with loved ones, friends, and other trusted people. Help survivors take practical steps to resume ordinary daily life. For example, daily routine, rituals, whatever they people doing. Help survivors take practical steps to resolve pressing immediate problems caused by disasters like loss of functional vehicle, inability to get relief voucher. So whatever, so help into those things also. Then facilitate resumption of normal family, community, school, work, roles, activities. So these services and these things should also become normal. Then provide survivors with opportunities to grieve their losses. There definitely would be a lot of losses, uh, personal losses, people losing near dear ones, or loss of houses or other things. Help survivors reduce problematic tension, anxiety, or despondency to manageable levels. Support survivors, local helpers through consultation and training about common stress reactions and stress management techniques. And observations by disaster mental health specialists were assisting these survivors after a disaster or immediately they would be part of the response teams. And what all is suggested to reduce this stress symptoms and promote post disaster adjustment. So what do you suggest for that? The first thing is initial mental health interventions. So what are these? So these are very practical things, pragmatic. So stages will be when first is protect. Protect survivors from further harm or further exposure to traumatic stimuli. So, any protect them from further harm or trauma. So, create shelter or safe places for them. It may not be required, but it may be symbolic. But that will also psychological help would be there. Let's say they already have, so they may like to move out of their places and shift here for fewer traumatic stimuli people see, hear, smell, taste, and feel, the better they will be. Protect survivors from onlookers and the media. Yeah, that also from the public layer, keep them away. Then direct. So kind and firm direction is needed and appreciated. So you have to direct them. So direction need to be given because survivors may be stunned, they may be in shock or experiencing some degree of disassociation. So direct ambulatory services, that is to moving them away from the site of destruction, away from severely injured survivors, and away from continuing danger. So you move them away from there. These are the direct interventions. Then connect with them. So they would have lost, these survivors would have lost connection to the world they are familiar with. So, supportive, compassionate, non judgmental, verbal, non verbal exchanges may help them experience a reconnection to the shared social values of altruism, goodness, or human nature, good side of it. However, brief the exchange or however temporary its effect, such relationships are important elements of recovery or adjustment process. So, help survivors connect with their loved ones with accurate information and appropriate resources with where they will be able to receive additional support. Then next phase would be triage. So majority of trauma survivors experience normal stress reactions, but some may require immediate crisis intervention to help them manage intense feelings of panic or grief. Signs of panic include trembling, agitation, rambling speech, erratic behavior. And signs of grief, it could be in loud wailing, crying, rage, making, shouting, so other things, rising a din, so like that. And if these signs of panic and grief are there, then attempt to quickly es- establish a therapeutic rapport, ensure survivor safety, acknowledge and validate the survivor's experience, offer empathy, and if appropriate, medication as necessary can be also used. So triage for you should have this or psychological intervention should also be there, and then select, identify key resources like Red Cross, Salvation Army, local state health departments for basic emergency assistance to help them. These resources could be used whichever is available in your area. Now, second thing is crisis intervention. So, three stages of intervention with different, these all, each stage requires different level of involvement. The emergency phase, early post impact phase, and restoration phase. So, in the emergency phase, immediate period after the disaster strikes. Early post impact phase. So this is after this disaster strike onset until approximately 8 to 12 weeks. So this stage covers, that means about 2 to 3 months it will continue. And third is restoration phase, marked by the implementation of long-term recovery program, generally beginning at about the 8th to 12th week, that is after the early post-impact phase. So, so be aware that the needs of individual members of a community can vary. They have different needs. So type of intervention strategies could be that provide direct services as soon as possible after the disaster. So required temporary bringing in outside experts also for this. That needs assessment, planning, and service delivery should be done in coordination with the local providers, those who are going to give this service. Outside help should at no time be imposed. Just because psychological intervention would be different from the normal medical interventions for casualties. So, so it should not be imposed on them. They should not get that feeling. It should be respectful and coordinated with the local resources. I think personal intervention. Adamu, you can also invite people. I think you are also co-host now, isn't it? Adamu, you are also co-host or not?
Yes, sir, I have been admitting. It's just that
Okay,
my
yeah.
eyes
Thank
was
you.
on the slide. I couldn't see him earlier. Sorry.
Yeah, yeah. Thank you. Now, so then empower local care providers for uh, so that they can have increased responsibility for delivering services in the community. So they could have been provided in-field training from beginning of the intervention, and encouraging local providers increase professional self-esteem and helps local resources expand quickly. Then work with key community figures and leaders, local media, government institutions to make them aware of the benefits of early community based interventions. So, the care providers from within a community may also be overwhelmed and be traumatized. They also require psychological interventions. So, that also should be kept in mind. Ensure that comprehensive professional support and supervision are available for them so that they may also attend to their own mental health needs. Then debriefing. So there are three types of debriefing: operational, psychological, critical incident, stress debriefing. So operational debriefing is routine and formal part of a organizational response. Mental health workers acknowledge it as an appropriate practice that may help survivors acquire an overall sense of meaning and a degree of closure from the traumatic disaster event. Psychological or stress debriefing is a variety of practices for which there is little supportive, knowledge about it. So psychological debriefing may not be appropriate mental health intervention. And critical incident stress debriefing, this is formalized, structured method whereby a group of rescue and response workers review the stressful experience of a disaster. So this was initially earlier developed to assist first responders such as fire, police personnel, and it was not meant for survivors, but so it is basically it started with for the rescue workers. S- CIDS, critical incident stress debriefing. So CIDS includes pre-crisis intervention, disaster or large-scale demobilization, and informational briefings, staff advisement, diffusing, one-on-one crisis counseling or support, family crisis intervention, and organizational consultation. So, out of this, if it is these three types for whom it is meant, I think you can understand, like critical incident stress debriefing uh, is not meant for these victims of disaster, but for those who are responders in it. That means those outside workers who come for disaster relief. Just a minute. Now, next thing we can see is the follow-up services. These are the basic thing of to prevent PTSD and other negative consequences. So early intervention uh, would help in before the problems become chronic. It can help, but it is very difficult to time the treatment in this case. The timing of follow up will also depend on other factors like readiness of the survivors for this uh, help, psychological intervention, nature of trauma, effects, and nature of service delivery setting. So, what you see is that it is not so clear cut like other medical services. So these have to be done very carefully. It should not become a negative impact or be counterproductive. Survivor readiness. So many survivors initially may not attend the preventive mental health activities, or they may not, like the referral to for psychological help. So they may not be ready for getting this psychological intervention because they are coping with practical problems and like findings are their housing, insurance claims, other things, practical physical things, other treatment. So all this they would be facing emotional trauma, and generally they may not recognize the need for this intervention. This is called they'll be in a denial mode. So they may not recognize need for the services because they may expect that the emotional reactions are short term and will pass over. Now, what are the nature of traumatic events? So this is another aspect. So the follow-up services depends on the nature of trauma. So sudden outset, So these services may be delivered within a few weeks after the event. Sudden onset disaster, and then supplemented over the long term. Follow-ups would be there. For other trauma over extended period of continuing exposure to severe stress or negative consequences like loss of houses due to disaster, medical treatment, serious injury, all these could uh, lead into trauma. So follow-up in such cases should be delivered for longer period. When possible, follow-up services should also correspond with times when trauma-related problems may increase, exacerbated, like some memories come back, anniversary of a trauma event, and things like that. So, like in say those who are in terrorist violence, so they may be involved in criminal trials, court cases, and things. So that may extend the trauma. So these proceedings could be stressful. So this along with these activities also then help would be required. Now, nature of setting also. So post-trauma services delivery will they vary differently depending on the nature of the setting. Say, so assault survivors, they are seen in medical settings because they would require a lot of help. Soldiers in war injuries offered, some sort of a psychiatric uh, along with their treatment, other injuries. So these cases they could be there. Hurricane floods survivors may be gathered together at community shelters. So nature of setting in which these victims are there at subsequently would also uh, lead to the type of intervention. So some places routine, systematic, adequate resources and follow up with all survivors is possible. And this nature of setting will also influence uh, who all are available or who can deliver this mental health related follow up, whether it is mental health professional, medical professional, para professional, or others. So, for follow up services, educational information for survivors will include help normalize common reactions to trauma, improve coping, enhance self care, facilitate recognition of significant problems, and increase knowledge of and access to services. Now, this type of information can be given. So, this could include public media, community education activities, written material, so other thing. Now, follow-up activities are survival and family education. Follow-up activities may include education, screening, referral, and treatment. So, follow-up activities for survivor and family education. So, the trauma survivors, educating trauma survivors and along with their families helps in normalizing common reactions to trauma and make them better cope with it. Then follow-up screening, it early identification of risk for negative outcomes could be there. So there could be then uh, either you facilitate prevention or referral and treatment. So mental health providers can screen for current psychopathology and risk factors for future impairment. So, by interviews and risk factors can be identified. Then, referral is given for crucial follow up activities. So, appropriate mental health service is necessary. Now, screening could be conducted in formal, informal ways to identify who needs a referral. So they avoid embarrassment, fear of stigma, cultural norms may prevent these survivors from seeking help because the stigma, that oh, you're going for a mental problem, so that should be prevented. So treatment, brief and specialized intervention effectively prevents PTSD and in some groups of trauma patients. So there are a lot of work being done on them. Treatment of acute stress disorder is indicated for the small proportion of people at risk for developing long-term PTSD. So these people are screened. So some require short interventions and some could be screened for acute stress disorder. So more treatment is required for them. They could be targeted brief interventions, and trauma survivors may benefit from ongoing counseling also. Now, maximize the follow-up services. Uh, then, what are they? So, very few people use the services, mental health services. So there is a. This is maybe because they are unaware of these, or they do not perceive the need for it, or they lack confidence in the service, or negative attitudes toward mental health care. All these could be the reason. So those who go for planned follow-up and outreach services, they should consider how best to reach trauma survivors and how to educate them about the source of help. Then also to market these services to the intended recipient so that they accept them. So after the traumatic event, there is chaos. So the workers systematically obtain detailed survivor contact information to facilitate later follow-up. So also those providing outreach and follow-up services actively approach survivors when and they go and meet them. And also self-care and self-help in these abnormal events with stressful experiences. So help of family and friends, people can feel better. Now let us see what is PTSD, post-traumatic stress disorder. This is a serious psychological reaction that develops in some people following experience of overwhelmingly frightening or traumatic events. PTSD is an anxiety disorder that results from intense horror, fear, helplessness in response to traumatic events. Events could be military combat, violent personal assaults, severe vehicle accidents, natural disasters, bearing witness to assault or serious injury of another person, hearing about serious harm or death of a close friend or relative. Now, what people vulnerable to develop PTSD? Those at risk, they could be anyone who has been victimized or has witnessed a violent act or who has been repeatedly exposed to life threatening situations. Survivors of unexpected events like car accidents, natural disasters, major catastrophes, and disasters caused by human error, industrial accident. And professionals who respond to victims in trauma situations. Then survivors of domestic violence and intimate partner violence, rape or sexual assault or abuse, physical assault such as mugging, carjacking, and other random acts of violence like those take place in public. Children who are neglected or sexually, physically, or verbally abused, or adults who were abused as children, combat veterans or civilian victims of war, those diagnosed with life threatening illness, people who learn of sudden unexpected death of close friend or relative. So these are the types of people who can be there. So follow up for the survivors of severe stress should be done. Now symptoms of PTSD. Now 1/3 or one in every three disaster survivor experience um, anxiety disorder or depression. So another thing is the categories or clusters of symptoms. They are reliving the event through recurring nightmares, avoiding reminders of the event, including places, people, thoughts, or activities, and being on guard or being hyper aroused at all times, feeling irritation or sudden anger. And the other problems could be psychiatric problems like depression, dissociation, self destructive behavior like addiction to alcohol, drug abuse, suicidal impulse, uh, so many other things. Physical complaints, stress related conditions like chronic fatigue syndrome, stomach pain, digestive problems, irritable bowel movement, alternating bouts of diarrhea and constipation, eating disorders, many things can happen. Okay. We'll just have a short break, then we'll continue with these phases of PTSD.
Okay, sir.
Yeah.
The only lady in the house have joined. You are welcome, Onsa.
Thank you. How are you?
Fine. You are welcome.
Mm, thank you. How are the lessons going?
Very interesting and fine.
Yeah.
You are welcome.
Mm-hmm.
Yeah. So let us resume on the psychological rehabilitation intervention. Uh, this is we are covering it in more detail because these are not covered anywhere else in your. So I thought. Now, what are the phases of PTSD? PTSD. So first is the impact phase. So most people respond appropriately during the impact of a disaster. They react to protect their own lives and the lives of others. So this is a basic natural reaction. So, but during impact phase, some people respond in a disorganized and dazed manner that they are not able to respond appropriately to protect themselves. Such disorganized or apathetic behavior may be transient, but sometimes it may extend into post-disaster period. The affected people are maybe wandering helplessly. So their reactions may reflect cognitive distortions in response to the severe disaster stressors and may for some indicate a level of dissociation. So several stressors occur which may pose uh, subsequently have consequences for the person. It could be the threat to life and encounter with death, feelings of helplessness and powerless, loss for loved ones, home, possessions, dislocations, separation from loved ones, home, family settings, neighborhood, community, then feeling responsible, feeling as though they have done more, then inescapable horror, being trapped or tortured, human malevolence, particularly difficult to cope with a disaster if it is seen as a result of deliberate human actions. Then immediate post-disaster phase, recoil and rescue. So this phase where there is a recoil from the impact and the initial rescue activities commence. So initial mental health effects may appear like people show confusion, are stunned, demonstrate high anxiety levels. Emotional reactions will be varied and depend on the individual's perceptions and experience of the different stressor elements. Necessary activities of rescue phase may delay these reactions and they may appear more as the recovery process get underway. So these reactions could be delayed also. So it's like reactions like numbness, denial or shock, flashback and nightmare, grief, reaction to loss, anger, despair, sadness, hopelessness. Then in the recovery phase, the- which is the prolonged period of adjustment or return to equilibrium that the community and individuals must go through. So this commences when rescue is completed and individuals and communities face the task of bringing their lives and activities back to normal. So it depends a lot on the extent of devastation and destruction, along with the injuries and lives lost. So it is associated with a honeymoon phase deriving from the altruistic and therapeutic community response immediately followed the disaster. So what it is saying is that at the time of disaster, people may not feel this thing, but it may set in, you know, after the initial disaster is, the gravity of the situation. They are involved in it. immediately in saving lives. So after that, it sets in. So at this time there is acute danger, and the priority for all basic safety and survival. So once they are secured after this priority, so they, these other things, they come out, and then the people feel frustrated now. So the emotional needs may be very significant for the affected people, those who are severely affected. Now, what are the therapies for PTSD victims? So therapies are like cognitive behavior therapy. So cognitive behavior therapy, CBT, for PTSD, which could be including exposure therapy, where the patients are asked to describe their traumatic experience in detail on a repetitive basis in order to reduce the arousal and distress. Cognitive therapy, focusing on helping patients identifying their trauma related negative beliefs and change them to reduce distress. Then stress inoculating training, where patients are taught skills for managing and reducing anxiety. So breathing, muscular relaxation, self-talk, so like that, yoga, other things can be done here. So it in this treatment, CBT treatment involves some combination of these methods we discussed, along with education about PTSD and development of good therapist patient relationship. And there could be other methods may be added to for related problems like anger management training, assertiveness training, social inclusion, social skills training, communication skills training. So all the things could also be added for it. Then eye movement desensitization and reprocessing, EMDR. This involves the patient bringing to mind images of the trauma while engaging in back and forth eye movement, while alternating one's attention back and forth using taps or sound. So these are all psychological methods. So a lot of research is done on this. Then psychodynamic therapy, because psychodynamic does not focus on symptom reduction, but they focus on more fluid intra and interpersonal process. So very little is done on this particular aspect. Then group therapy. So group treatment has seen to be beneficial effect for psychological distress, depression, anxiety, social adjustment, but still a lot of work is being done on these things, on this. Then inpatient treatment. So there may be a inpatient's requirement for PTSD and trauma related conditions. Then marital and family therapy is another type. Marriage counseling is typically uh, done in domestic violence. Then social rehabilitative therapies. So these are like teaching social coping and life functioning skills. So they are effective for chronic schizophrenic and other groups of persistently impaired psychiatric individuals. So PTSD, not much success is there in this. Hypnosis. Uh, hypnosis is used with trauma survivors. So But again, these are also not very clear that any beneficial effect are there. So other things while treating PTSD patients. So these patients after disaster, some of them may be having pre-existing psychiatric disorders, including pre-existing PTSD at the time they experience trauma. And this recent trauma of the disaster would exacerbate and increase the pre-existing conditions. So their assessment has to be carefully done to note this aspect. Also, trauma will precipitate the disorders also. Then it is essential that treaters educate patients about their medications, interactions with alcohol, other medications, or substances of abuse. Now, mental health management of disaster rescue and response workers. So, as these workers also face death, physical injury, potential loss of their co workers, friends, devastating effects on communities. So and also they are in physical danger also at so they are at risk for behavioral and emotional readjustment problems. So psychological problems uh, after disaster experience could be emotional reactions, temporary feeling of shock, grief, cognitive reaction, confusion, disorientation, indecisiveness, physical reactions of tension, fatigue, edginess, and interpersonal reaction on in their relationships at school, work, friendship, marriage with parents. All this they'll have could have distrust, irritability, and others. Now the stress symptoms resulting from disasters. For the rescue workers, normal stress reactions and disaster experiences promote personal growth and strengthen their relationship. Mild stress would may be good for them. It will develop them more, make them stronger. But many experience severe stress symptoms, so which will lead to PTSD. So these also they'll have a feeling of anxiety disorder, PTSD. So they experience dissociation, intrusive re experiencing, extreme attempts to avoid disturbing memories, extreme emotional numbing, hyper arousal, severe anxiety, severe depression. So, people at greater risk for severe stress are those uh, and who experience life threatening danger of physical harm, exposure to gruesome death, bodily injury, or dead or maimed bodies, extreme human violence or environmental destruction, loss of home, valued possession, neighborhood, community, loss of communication with relatives, intense emotional demands, extreme fatigue, weather exposure, hunger, sleep deprivation, extreme exposure to danger, loss, emotional, physical stress, exposure to toxic contamination. So, how do you manage stress during a disaster operation? The ways, some of the ways could be develop a buddy system with co-workers, encourage and support your co-worker, take care of yourself physically for exercising regular and eating small quantities of foods frequently. Take a break when you feel your stamina, coordination, or tolerance for irritation is coming up. Stay in touch with family, friends. Diffuse briefly when you experience troubling incidents and after each work shift. So after a disaster, attend a debriefing. This is for the workers, or try to get one organized 2 to 5 days after leaving the scene. Talk about feeling as they arise. Don't take anger too personally. Give your co-workers recognition and appreciation of a job well done. Eat well and try to get adequate sleep in days following the event. Maintain as normal routine as possible, but take several days to decompress gradually. So after returning home, how to manage stress? Catch up with your rest, slow down, understand that it's perfectly normal to want to talk about the disaster, expect disappointment, frustration, and conflict. Don't be surprised if you experience mood swings. Don't overwhelm children with your experiences. If talking doesn't feel natural, other forms of expression or stress relief could be done. Work out for rescue workers. So the each day, one at a time, in after the disaster, provide a new opportunity to fill up. Fill up is FI means focus inwardly of what's most important to you and your family today. LL is look and listen to learn what you and your significant others are experiencing. And UP is understand personally what these experiences mean to you. Then debriefing, we've been talking earlier also, would for the mental health workers, when they come, consider some form of debriefing, and this could also be done. So debriefing, when it is done, should be conducted by experienced, well-trained practitioners, not mandatory. Utilize some clinical assessment and potential parties of the participants, and be accompanied by clear and objective evaluation procedure. So this is the important part about this. Now, any question you want to ask? Yeah. I think again my system is hanging up.
Hello.
Yeah.
Yeah, this is Evaristo.
Yeah.
I I wanted to find out mental issues versus PTSD. Uh, is it that PTSD is an outcome of mental health issues? Maybe you elaborate more on the similarities or the differences between mental health and PTSD.
Yeah, we have covered it actually in quite some detail, but on the PTSD is one of the major post-traumatic stress disorder. So, as the name says, it is post-trauma, post-traumatic, and it is a stress disorder. So that is PTSD. So we covered in detail also here, but it could happen due to any type of trauma. You know, people who are involved in violence, who have seen a lot of shock or lot of destructions, all these things could be what they may experience. So yeah, you are right in a way that um, so it is a because of stress, it's a psychological disorder, and it takes time to set in. It is not that today the disaster happened and person will be diagnosed immediately. No, it will take a lot of time for this to come up. That is what PTSD could be. What you can say, okay, yeah.
Thank you.
Because you read through this, it's covered in very much detail also in this unit. What we've been covering, most of the things, in fact, it is a PTSD, uh, PTSD, what we've been covering here. I think again my computer is hanging. Hopefully, yeah. Okay, now we'll cover the next important unit, unit 14. Uh, it covers, it's the practical manual, and so practical manual, it is about describes the steps to be taken for management of disasters in pre-hospital phase and the of standing operating procedures for the hospital management of disasters. Okay, now what in these two phases of disaster medicine, uh, pre-hospital phase deals with the provision of health care to the victims of the disaster at the site. And the guiding principle is to provide immediate rescue and relief to the injured and rehabilitate them at medical camps. The badly injured who require immediate hospitalization are referred and transported to hospitals for this purpose. So these are the two stages. So we will discuss the guiding principles of these two phases. My cursor is stuck, so I can't move so easily on the screen. So okay, but let's do with it. So first is the pre-hospital phase. So uh, pre-hospital phase aim is to reduce death, disability, disease, and discomfort and provide optimum medical care under the circumstances. So there'll be three stages taken into account. First is at the disaster site. Second is the first aid medical post over there. And third is the transportation to the hospitals. So disasters site arrangements. Now we are looking at the arrangements actually in all these in this unit. So site management, it it promotes immediate survival of as many victims as possible with the resources available. Rescue and evacuation of victims from the site. So this is what is the main thing which is at the site. We spoke of at the on first we are talking of the disaster site. So disaster site we have further subdivided into three. First is the disaster site, that is where the victim is stuck, he's injured, he's affected. Then he's moved within the site only to a medical aid post which has been created, or and then from there transportation to the hospital. So these are the three things, and basically to have maximum people survive. That's the aim. Rescue and evacuate the victims. This is the aim. So for the pre-hospital stage, the checklist should include. So that is very important. What all you should have in the confirm the disaster first thing, then make an initial rush visit to the site. Then third thing is identify there the kind and type of disaster, extent of disaster, approximate number of victims, still active risk. Any active risk is still there because of the disaster or any other thing, and access route, which is a route. Then fourth is identifying and mark the location of first aid post or post as required, and then starting triage and medical care. Now, what is the first aid medical post? Is to provide medical care to as many victims as possible so as to minimize discomfort, disability, disease, and death. So, to save as many lives as you can. So, people over there, staff over there, must quickly sort out the victims and provide initial triage. So, triage we covered, and the protocol over there is first is for the staff: protect yourself, protect others, protect victims, control panic, treat as many as possible, transport victims to safer areas or to hospital, be respectful to the victims. Then CPR, that is done over there. Immediate responsibility of resuscitation are to recognize signs of cardiac arrest, protect the patient's brain from anoxia by immediately starting artificial ventilation of the lungs and external cardiac massage, and call for help. So CPR must be initiated within 3 to 4 minutes in the order to prevent permanent brain damage. So CPR, we can, various details are there. Okay. Third thing we spoke of at this place is transportation. Here the objective is shift the victim with due safety and speed. So victim is stabilized, then he should be rushed to the designated hospital. So vehicles to be preferred are carrier vehicles which can transport more number of victims with safety and speed. If equipped ambulances are available, it is a great asset. But do not wait, as speed is essence. So what are the do's over here? Coordinate with ambulance vehicle in charge, organize different categories of appropriate vehicles based on triage of victims, coordinate the boarding operations, keep a record, inform the hospital of the or the destination point regarding the status of the transport victims. Now let's see the disaster phase. So here, uh, provide a guide for the efficient this of here. This is to you should be able to guide for the efficient effective management of hospital resources in a disaster situation. Hospital personnel have to understand disaster management system. These are the command, control, communication. Staff in any hospital should be trained for any disaster, big or small. Actually, all hospitals should be trained. Effective management of hospital will optimize resource utilization for efficient and effective care to maximum number of casualties. So, all hospitals should have a disaster management plan. This plan lays down the casualty emergency management for meeting any disaster. Plan lays down for standing operating procedures for casualty department and each category of staff in the hospital and casualty department. So there will be disaster committee headed by the medical superintendent, who is the head of the hospital. He will be the chairman, or with the members could be officer in charge casualty and emergency services, head of surgery department, head of orthopedics, head of medicine, head of anesthesia, head of pathology, head of forensic department, head of pediatric department, chief nurse superintendent, security officer, and sanitary officer. So this community should meet once in 6 months, and they should formulate a disaster plan for the hospital and review it after every disaster. So the plan should basically identify resources, identify persons who will activate the plan, and identify resources from where additional facilities can be mobilized. Now, standing operating procedures in casualty or action plan. So, first is information received, then confirm it. Inform head of the hospital. Call for alert. Activate disaster plan. Mobilize disaster team member and other staff. Send advance team in ambulance if asked for. Organize team for triage. Create additional space for receiving victims and their treatment. Ensure availability of essential drugs and other supplies. Coordinate with security officer and inform police. Seek additional force if required. Alert mortuary services. Alert blood bank. Public relations officers should be direct to handle the media. All the TV, media, radio personnel. Then checklist for essential equipments in the hospital: oxygen point and cylinders, suction points and apparatus, blood pressure apparatus, ambulance bags, adult and pediatric, then larynoscopes, adult pediatric nebulizer, ventilator, defibrillators with cardiac monitor, torch, electrocardiogram machines, glucometer, ET tubes, tracheostomy tubes, CVF lines, chest tubes, syringes, cannula, drugs, life-saving and essential linen, intravenous stands, trolleys, wheelchairs, communication system, telephone, paging, civil and electric services, water supply. So everything which is to be thought of should be listed, and their SOPs for staff. So what is the SOP for Chief Medical Officer casualties? CMO has a pivotal role in management of casualty and emergency. So his duties are informing the medical superintendent, mobilizing disaster team members and other ancillary staff, sending advance, trained team in ambulance to the site of disaster if called for. Ambulance should be equipped with first aid equipment, ensuring space, beds to accommodate patients and relatives, ensuring availability of drugs and other supplies, augmenting patient transport facility within the organization, render effective communication within and outside hospital communication. All so this you should read through it. It's a very long list for the CMO casualty, then specialists, then senior residents, then junior residents. What all they'll do? Deputy nursing superintendent, assistant nursing superintendent, nursing sister in charge. What is their duties? Nursing staff, then nursing attendant, nursing orderly, ward boys, and ayas are the people, boys, girls are the ayas, it's called here. Then security guard, what is their duty? Stretcher bearers, the cleaning staff, sweepers. All this is an important aspect. Yeah, any question on this aspect? This is a very important, must go through. You will learn even the other aspects. See, these we covered this earlier also, but here this is consolidated in this. So that's why it is a yeah. So next one is case studies of medical and health interventions in disaster management. So some case studies are there uh, of government, non-government initiatives in natural disasters. It's talked about tornado West Bengal in 1998, super cyclone Orissa 1999, flood West Bengal, earthquake Gujarat, tsunami, floods. I will suggest you should read this in completely. These are good case studies for this aspect of medical aspect it is covered. So you'll find that these two case studies of Gujarat earthquake and Orissa cyclone, it has been there in every type of our this course, uh, and of course others are there because these were quite a big one. Every aspect has been covered. So these case studies they cover this. Now see, the disaster medicine, when we have this core, it's a multi-team based activity. Actually, all aspects of disaster are multi-team. But here, medical aspects also. But here, you will involve the government, NGOs, CBOs. CBO are the community-based organizations. SHGs, self-help groups. In fact, these are the most important ones at the village level, at the local level. So then individuals, private sector, media, academia, armed forces, professional institutions in medical and public health management of disasters. So they all, why are so many of them? They are involved in the prevention, preparedness, response, and recovery aspects during disaster medicine. So their role is collaborative in planning and implementing various aspects of disaster. Now, basically, the plans are laid down and by the government. They facilitate participation of various institutions in this complete aspect of disaster management. But NGOs, CBOs, SHGs, that is the community organization, usually carry out disaster preparedness and relief work in the community. They are the best to work with the community. So they take the task of educating and training community in first aid, hygiene and sanitation, community health, food and nutrition, shelter, evacuation techniques, debriefing, etc. So private sector also plays a role in finance and providing experts. Professional institutes, colleges, institutes, universities also uh, give advice of various types. They can give specialized focus on it. They help in developing standard operating procedures, community-based instructions, and lessons. Technological institutions help the disaster management authorities in application of GIS, MIS, expert systems, telemedicine. All these can be put in. Academic institutions conduct the evaluation studies, post-disaster reviews, reports to the government. Educational institutions like this one you are doing is the community awareness, disaster preparedness plans, and in villages they can be doing these type of things also. And media plays a very important role in public opinion, mobilizing community, publishing their suggestions for improvement and change in disaster plan. So they all work together in a concerted, consistent way to mitigate adverse types of disasters. So I'll cover super cyclone Orissa. The cyclone was of very high magnitude, and the strong winds continued for 36 hours. And Yeah, it had gone away. So there were a lot of people affected. 129, or you can say 12.9 million people in 12 districts, and more than 10,000 people died, and uh, half a million of the livestock was destroyed, killed, and total of 1.6 million houses were destroyed. So now there were a lot of this magnitude of disaster. The state government ordered all its officers and other department to assist health department in managing various health related activities like receiving medical supplies from different places, organizing drug distribution, receiving medical personnel arriving from different places, providing for their boarding and lodging. So distribution of halogen chlorine tablets amongst the various workers. So these tablets are basically the water purifying tablets. So these were also airdropped, and instructions on how to use the tablets were given in the local language. The awareness of the need to disinfect drinking water coupled with react practice of drinking water from tube well was responsible for some cases of diarrhea cases and deaths related to it. Now, it was a so along with government, various educational bodies also took initiative. I don't know. Again, it has run off. Yeah. Now, this was a lot of all the local people were involved. Government bodies were involved, and so like subsequently immediately after that there was a lot of intervention. All these the survey was carried out on checking how many what has happened, various role of various organizations, teams was there, and how they acted. So this is what briefly this contains. Now, I think these case studies best is you read them on your own instead of over here, um, because this shows what we have studied, what all has been done. But what we can summarize is that disaster management should involve all stakeholders, including government, corporate, NGOs, community, international organization, voluntary organization, households, and individuals, academia, professional institutions, and media. Next thing is it is advisable to take local administration into consideration at the time of distribution of relief, because immediately after the disaster there's a lot of relief to be distributed to help the people. So take the help of local environment. So this helps in finding the deserving locations for its disbursement and its security also. Relief materials provided should be based on the cultural, social, and geographical aspects of the affected population so that it can be effectively utilized. Locals should be involved in all stages of disaster management. Women should be engaged in pre and post disaster stage. Education and training programs should be used as important tools for imparting information and awareness about disaster management. Disaster task force should be constituted in every village comprising youth. Community preparedness on disaster management should be prepared for vulnerable communities. Disaster management programs should be linked to livelihood programs. This will provide incentives to the community to take part in disaster management program. Information and communication technology should be made use of in disease surveillance and epidemiological studies. So we have covered this aspects. Now, anybody would like to ask something on what we have done on this covered? Yeah, or you would like to ask on anything else? Then otherwise we can finish. And today is the last session on this. Yeah, you want to ask anything? Okay. So anybody wants to say something? Yeah, Adamu, please.
No, it's just to remind the participant to write attendance. I noticed that some of us used to forget to write our attendance in the chat they
Yeah,
set. It is being recorded. So please, those who did not write attendance should write their attendance, please.
yeah. Please write your attendance on the chat. This thing on the message. Just write your name. Okay. So we can close for today, and I wish you the very best in your this course and otherwise also. And those who want to continue with the project, they can send me their project with the my on the email, and then I'll send you the details. And maybe I will have one personal session with you once you send me the synopsis on whatever way. I'll send you an email. We can have a either meet on this only Google Meet, or we can have a WhatsApp video call, anything, or any other thing. Okay, so we can close for today. Thank you very much. Bye bye.
Thank you very much. Thank you. We
Bye
really
bye.
appreciate it. Bye-bye. Whew. No, this one easy. Baby, nah, give me five. Nah.